are coming to our next presentation. Now we'll be shifting ourselves from inner journey of healing to the analytical lens of functional medicine that is particularly built on diagnostics. Because before we talk about protocols, we definitely need to understand patterns, data, and the root causes that are driving the autoimmunity in the first place. Our next speaker is someone who has completely changed the way practitioners in India are looking at diagnostics. Johan Tengra is the founder of Biohacking India and a diagnostics focused practitioner and an educator who loves to work with complex data. He changes complex data into clear and actionable protocols, and his own journey actually began when normal reference ranges couldn't explain his own symptoms. Again, what we see is all of this is passion driven. We can see most of our speakers, they have themselves faced a lot and have come up with these wonderful ideas. In today's session, what Johan is going to tell us about is beyond antibodies, the diagnostic first roadmap for an autoimmunity in alopecia areata and type 1 diabetes. So please join me. There are two powerful case studies that Johan is going to show. So please join me in welcoming Johan Tengra onto the screen. Let me bring him on the screen. Very, very good afternoon. How are you doing?
Hey Amarjit, how's it going? Good to be here.
Fantastic. We are enjoying every minute of the conference, and you can see everyone has sent you a welcome. The screen is all yours, Johan.
Thank you so much. I'm going to try and mirror some of your infectious energy in my presentation as well. Yeah, let's just get started without wasting any time. Just give me a second. I'll start my presentation. Okay, let's go. Hey, can you guys see my screen?
Yes, we can.
Lovely. Okay, hello everyone. I'm sure you all have had an intense time, over the last 1.5 days, just absorbing, so much material on autoimmunity, and functional medicine itself is so complex. So I'm gonna try and make this as practical, as easy to understand as possible. I'm gonna throw a couple of stories in there so that y'all can, relate beyond the science and everything. Yeah. So my talk is basically gonna be about like Amarjit, described, how I go about doing very in-depth testing on every patient that I see. But in today's context, we're talking about two autoimmune cases that I've worked on over the last year or so. So yeah, let's get started. This is going to be the kind of layout. I'll start with brief introduction. We go into the nitty-gritties of the case studies, and then we close with conclusions. Great. So I just need to minimize this so I can see my screen. Yeah. Okay, so if anyone out here is familiar with my work, you'll probably have wondered at some point, like, why am I so obsessed with, like diagnostics and root cause healing? Like, Johan, why can't we, just take a few supplements and fix things just based on symptoms and some basic blood work and all? I actually started that way. So I'm gonna just give a brief about like why I even got into this in the first place. So I'm a complex patient first. So I have a lot of empathy for what patients go through, whether it comes to cost, whether it comes to compliance, whether it comes to just getting frustrated with not, getting headway with symptoms and things like that. I've experienced all of that for say 7+ years before I cracked my own thing. And that was the primary motivation for me to even pursue this path, because I had to pretty much like go against all odds and just keep investing in my learning curve. And over time, like as I absorbed more, as I kind of took more courses, pursued academic education in the space, yeah, like I started applying all of that on myself one by one, and things started getting better. So just a brief background about myself. Like before I got into this, I was struggling with extremely bad seborrheic dermatitis. So it's a chronic inflammatory skin condition where, like you all must be familiar with dandruff. So that to like a very extreme scale, like very thick flakes. And then the same spreads to the face and the like chest also in a couple of people. And that was the case for me. So that, then cystic acne, like from school itself, very, very bad acne, like on the face as well as on the back as well. Extreme chronic fatigue. I would sleep for like 12, 14 hours in a day and still wake up and yawn 50 times throughout the day. burping, like if I'm giving a talk right now, like, just be kind of burping like 2, 3 times every half an hour. So without exaggerating that. Tonsillitis, like constant nasal drip. Tried hitting the gym for 3 stints. Like I remember once, just as I got into like first year of college and sometime in my degree, but like gave it my all, hired a personal trainer, but like no headway out there. And yeah, because of all this, of course, the psychological toll, the insecurity, the confidence taking hit, all of that. Along the way, like I basically, because of all this, I started, following podcasts and trying different kinds of diets over the years. So I've done everything. Like I did organic diet, like initially, then I was a vegan for a year, then I did keto for 2 years, then I was like on cyclical keto for half a year. Then I did a carnivore diet for 2 months, like pure carnivore. That was quite useful because it helped me to discover some of my food sensitivities. Then I was like animal based for 2 years, and along with all this, like tried all the lifestyle hacks like sunlight, grounding, meditation, sauna. Even like bought a high end like infrared sauna at my place. But despite doing all of this, I would say like I barely got 20-25% of the way there. Maybe like some symptoms improved a bit, like others even worsened on some of these diets. So I was left scratching my head because you're, putting so much effort and like complying with everything to, I mean, it takes a lot of effort and a lot of planning to comply with any particular diet, as patients might be aware, and even practitioners, like goes without saying. So did all of that and still I was like barely, kind of anyway. So then I was like, kind of over the time I started to get the idea that diagnostics is really important because that's when you can really like find out things for yourself and then start, applying it. So then I just went deep berserk into like figuring out all kinds of tests and like did a lot of courses. And then over time, like I basically learned how to review the literature myself. So then just using all of that scientific research background also, then I just kept reading studies myself and compiling the best data all over the world on different blood tests, different other tests, like we'll probably touch on different symptoms, different diseases. And then today, like this is not today, I mean, like this is sometimes say 3.5 years back, I finally like fixed everything, like zero dandruff, no acne, no rashes, like 8 to 9 hours of sleep, high energy throughout the day, no chronic burping, and normal ability to put on muscle. And once I figured this out for myself, I was like, shouldn't just keep this restricted to yourself, should help other people. So that's when I started actually like seeing patients, having my own practice, and I consult for like diagnostic companies and yeah, a couple of other companies in the space. Okay, so why listen to me? I run Biohacking India. It's a diagnostics-led practice focused on complex chronic cases. So I see both ends of the spectrum in my practice. I see like really, really bad, like sick people with all kinds of diseases and symptoms. And then I also see health enthusiasts who maybe say like have some couple of minor symptoms, but they're really looking to optimize. Okay, so I do deep dive clinical consulting, practitioner training via 6 month course. So whatever I've learned and kind of gained from my clinical experience and research reviews and courses over the last 10 years or so, I consolidated into a like 6 month long course, which I did last year. How I work, so it's systems biology plus evidence-based interventions. I have a very like fine knack for trying to replicate what's seen in clinical trials on patients. That's my gold standard. Like I just read all of the clinical trials on every particular symptom and disease, on diet, lifestyle, nutraceuticals. There's thousands of these, and then I try to apply the best science extracted from that into patients, and then extremely practical, cost effective. So I'm always thinking about how do I reduce cost for patients, how do I make things as evidence based as possible so the results are much more likely than typical. And I also collaborate and consult with other companies in the space. Today I'm going to show you all two autoimmune cases that show the same kind of repeatable framework in action. This is my framework. Okay, basically, so I do in-depth history, and I have like a very long questionnaire which is more than say 55 questions long. So I capture the symptoms, history, triggers, the patient's comorbidities, like family history, all of that. So it's very important, like a lot of people just focus on the diagnostics, but then integrating the symptoms in the clinical history and just having the knack to ask the right questions to the patient, that itself, if you can know how to integrate that with the diagnostics, that can help you to crack most cases. We measure the system. So we're looking at least initially when I work with people, like I do cast a very wide net across different systems. And then subsequently, when they come in the future, then we're doing like specific tracking of what things we captured. But it's important to cast a wide net the first time so that, a lot of times like patients come to me with certain issues, but then they're not even aware about certain things. And then it comes up in the blood work or another test, like a genetic test or something that we do. And yeah, I mean, it just like changes their risk perception, or it helps to inform them and make tangible changes that can, reduce the risk of something they would have otherwise suffered from in the future. We prioritize, right? So now when we're doing so many tests, there's so much overwhelm, there's like paralysis analysis, you're just kind of scratching your head. There's so much data, like, so you have to have a way where you can rank things, you can relate it to people's symptoms, you can understand like what's for say disease prevention or optimization, and what's going to help the patient to solve like the critical symptoms. Like the first preference is always to fix the symptoms first, because that's what's affecting their daily quality of life and everything. And once we're through with that, then they can even get into a frame where now they can start thinking about, say, long-term health, or, reducing risk of different diseases. So you need to not throw everything at the patient all at once, but, rank things. Even within interventions, I go to great length to rank like what things have the biggest effect size in trials. So we're trying to use as lesser of a number of products as possible. And I also try to select interventions which affect multiple things together. Like if the patient is coming with hair loss and migraines, and as you all will see, like today's patients have kind of selected them that way, that they are, they have a lot of comorbidities along with the primary concern that they came in with. So I try to select interventions which affect like multiple things together, and then we retest and iterate. So yeah, they come in with the blood work symptoms, give them protocol, they follow that, we check in again after 3 months, we track what was off the first time, and then we keep the process going. There's more than that, like I do genetic testing also, and then based on that I can set up lifelong plans and everything, but not everyone does that. So at least with blood work, like this is my way of working overall. So today's case, like the first one's on type 1 diabetes. She was diagnosed in 2003. So yeah, just a quick kind of Q&A for the chat. So guys, you need to like answer one question for me. Tell me, in type 1 diabetes, what is the most commonly missed thing in clinical practice? Is it cardiovascular risks like high ApoB, high LPA, say micronutrient kind of deficiencies or insulin sensitivity issues, say like low magnesium, things like that? Sleep or stress physiology, or all of the above? Just like quickly type it in the chat. I want to see where you guys are at with this.
Do you want me to make a poll for you?
I'm good. I'm good. No, I just want to see like quickly where people are, thinking. Perfect, perfect. So you all are at the on the same page. Yeah, we're on the same page. Good, good. Okay, so let's go. You'll see why this is true in this case, personally. Yeah. Okay, so 32-year-old diagnosed with type 1 diabetes in 2003. Time point. So as I said, like month 0, we do baseline testing. Month 3, we do like follow up after protocol. This case's initial intent, like she wasn't aware that her labs were so bad. I mean, to kind of describe the profile of the case, she's like a typical person who's skeptical of, pharma and just the entire medical industry and all. And sometimes even skeptical about tests, like say HbA1c and all, wouldn't really take it seriously. Or I'll go into more specifics as we kind of unfold the case. But yeah, her initial intent before she got the data was just like, okay, I'm just curious to, kind of fine tune my health and fix some of my symptoms. After she saw a lab, she's kind of freaked out. And she was like, okay, now I want to regain my health and prevent damage, because some of her values were like really, really off. So we're not just dealing with a type 1 diabetes case. We're also working with a case who has chronic fatigue, insomnia, hair loss, gum bleeding, hip pain, finger and joint pain. So there were some RA-related markers also which were elevated. And this is what we saw after protocols. I'm kind of giving this to you all right now, then I'll walk you all through the process and we'll tie everything together. But yeah, so her fatigue improved after like finishing the initial like blood work and symptom-based protocol. Insomnia improved. Hair improved initially, like for say first 2 3 weeks. Then it kind of worsened on the GI protocol. I'll touch on this probably later. But then there's when we're working on pathogens and gastrointestinal infections, there's a concept of die-off or Herxheimer reactions. So yeah, I mean, like when we're killing pathogens, they're kind of shedding inflammatory molecules, and they have kind of dead you know particles which stimulate the immune system in some cases. So there's like some aggravation or worsening of some symptoms. And then yeah, like once the GI protocol was done, then she started improving again. The gum bleeding, 90% improvement here, which she explicitly stated. And then the hip pain and finger and joint pain. So out of both of these, the hip pain did improve. Like she did tell me that, but the finger joint pain did not improve. Okay, so this is the baseline. Like I'm trying to give you all a picture of even though she's already doing so much, like she was still where she's at. Like you all will understand when you all see her numbers, and if you all don't, I'll kind of explain it in simple language. But these were baseline meds and supplements. So insulin, she's taking fast acting 3 to 6 units per meal. So this is say if we consider the upper end, this is 18 units of fast acting insulin in a day, like six with every meal. And of course, that's a upper end baseline would be anywhere in the middle of these numbers. And then for long acting insulin, we're looking at 10 to 12 units. Like this is a typo out here. This is 12 units. And then if we look at the supplements that were already being taken, she's already on a lot. And some of these were actually worsening her glucose control, which is why it's very important to be particular with the research on individual compounds, the dosing and everything. Because a lot of times people just have a tendency, they'll hear things on podcasts or look into some mechanisms and just assume like something's good for something. But medicine's really complex. Like you have to hit the right dose, you have to make sure the test you're using is a validated test to actually pick up a deficiency or toxicity in that marker. There are all kinds of nuances with that anyway. But yeah, she's taking glutathione, gymnema, betamelin, ALA, chromium, B complex, black seed oil. You can see like she's already taking berberine, milk thistle, boswellia, curcumin, D3K2, krill oil, magnesium, inositol, collagen, glycine, like a lot of things thrown in the mix, basically. Yeah, so, despite all of this, we're looking at very little, say, improvement and very, very bad numbers initially when she first came to us. So this is the key point. Like, despite an extensive anti-diabetes supplement stack already, her baseline glycemia and cardiometabolic risk markers were still severely abnormal. Okay, so you all will understand like once I unfold the next slide. But yeah, these were her numbers typically. Like these are really, really bad numbers. So when she came in, we were looking at an HbA1c of 11.8. This is like dangerous territory. HbA1c, we're looking at fasting glucose of 186. A fasting insulin, of course, like it's going to be under one because she's pancreas cannot make any insulin. The clinical interpretation at baseline, I'll explain what the slide on the right is in a brief. But when we're looking at an A1C of say like 11.8, I already know with my reference range data. So I don't go by the reference range data that's typically, presented by labs. There are a lot of limitations in that. I basically just go with whatever I find in the research myself. So I kind of dig the studies because I have like a background to evaluate the literature myself. I review studies on each particular marker and then I find what is the data on what happens at different levels. So how we do ranges typically with conventional labs and all, it's very skewed. Like they're firstly just looking at averages, like statistical averages of people who typically have some issue going on, so you're not looking at like an optimal population to begin with. That's just the first problem. I mean, then there are many more problems with the ranges. So I put a lot of effort into just like, making sure my diagnostic template is as solid as possible. So because that's what decides the interventions ultimately. Right. So now we have solid data. This is just HbA1c, for example, but we have solid data looking at, if you're going at different levels of HbA1c incrementally, what outcomes do we see in like good studies, So you can see like just going from 6.5 to 8 is just 50% increased risk of worse diabetes complications like macrovascular complications. So this is retinopathy, neuropathy, nephropathy, things like that, stroke, heart failure. And then you can see like as you go above, that risk just keeps going up. First is just a 50% increase. Then it's like you go a bracket higher, it's twice as worse. Then you go a bracket higher, it's 2.5 times as worse. Then after that, it's like thrice as worse, like diabetes complications. And then like once you're going above, it's like diabetic ketoacidosis territory. Again, I don't want to go into what that is, but it's like a very severe kind of condition, which is mostly faced by type 1 diabetics, for which they have to go to the hospital and get IV insulin and things like that. Okay, so she's already coming in with a HbA1c of 11.8. Like I can just look at my kind of risk assessment, criteria and understand that she's at very high risk for, say, retinopathy, neuropathy, like kidney damage, eye damage from having high glucose, things like that. And of course, like long-term disease risk also super high. So when she just came in, only I asked her, like, have you been diagnosed with retinopathy? Because I can see her, kidney markers and things. So at least the nephropathy side, and even she had like mild neuropathy as well. I remember her complaining about, like having uh, some temperature kind of issues, with the hands, like feeling slightly cold and things like that. So yeah, like I asked her that, and initially she was, like, I know I haven't been diagnosed. This is really not an issue for me anyway. But I told her, yeah, at this level, like, even if you don't have it right now, this is coming, like if we don't basically, get this in control. So yeah, like then we went forward and you all will see how this case unfolded. So, uh, as I said, like when we're looking at a type 1 diabetes case, a lot of things are typically missed by, say, conventional practitioners or even like people in the kind of FM or alternative space. So the first thing that caught my eye is she has very high cardiovascular disease risk. Like her lipoprotein A levels are through the roof. Under 20 is optimal, 20 to 50 suboptimal, above 50 is like properly high level. So if we're looking at a starting lipoprotein A level of 80, this is a genetically set lipoprotein that increases the risk of cardiovascular disease much more potently than LDL cholesterol as well. And then we have ApoB, which is like a better way of looking at the atherogenic lipoprotein. So it's a protein that tags all the lipoproteins which cause atherosclerosis. Again, like atherosclerosis is not just caused by high ApoB or high LPA. They are the primary drivers, but then you have a lot of other kind of things which amplify the risk, diabetes being one of them, of course. But yeah, I mean, like if I see high lipids on someone, then you need to like get that in control. In fact, the lipid lowering targets are even more aggressive for people who are at high risk. So if someone has diabetes, then their target to lower ApoB is like even more than what you would have in a general person because they just have higher baseline risk overall. So this is a high risk combination for long-term cardiovascular burden, especially when paired with uncontrolled, glycemia. We'll see that when we see her kind of, further numbers out here. So this is what all like further tests I did over and above, say, conventional testing. Like we looked at organic acids, so I was able to pick up that she had a biotin deficiency from one of the markers out there, and there is research on like giving biotin as a supplement and improving glucose control. Like there's a couple of trials which have been published on this. We're looking at very low magnesium. This is serum magnesium. Of course, we didn't run a RBC magnesium on her because it wasn't available at the time. But yeah, even her serum magnesium is also a validated marker. Like a lot of people just think it's rubbish and the body pulls magnesium from the bones or something like and keeps the serum up. That's not true. Like we see in large studies of like lakhs of people, when people have symptoms of magnesium deficiency, the serum magnesium does decline. So it is a useful marker that way. And we're looking at free carnitine that's also quite low. So that would be contributing to fatigue as well. I'll kind of explain the connections between some of these, like serum magnesium, of course, like low magnesium does worsen insulin, resistance and stuff. And then we have like amino acid or neurotransmitter related signals. So we're looking at, I also measure like metabolomics in people who kind of, go down that route. So this is amino acids and organic acids testing. We're looking at very low tryptophan levels. This I think was surely like playing a role in her insomnia. Because like tryptophan deficiency is like seen to kind of cause insomnia problems. Tryptophan's a precursor to make melatonin. That's the kind of primary mechanism. And then ornithine is like the precursor to like arginine, citrulline. So even that was really low. Arginine levels are also really low. Even arginine has some data on like insulin sensitivity and stuff. And then pretty high homocysteine, like 20 homocysteine. Homocysteine being high increases the risk of stroke. So it's important to lower. There's an autoimmune signal as well. Her rheumatoid factor was 37. This is not, say, like, full blown RA. Her anti-CCP was negative. Like anti-CCP is a bit more important than rheumatoid factor for RA diagnosis. But yeah, she did complain of like finger pain, hip pain, and stuff, and she did have, say, low positive RF. This is another thing that I was kind of telling you guys about when it came to, some of the supplements she was taking. So a lot of times, some of the supplements we take actually harm us because we're not taking the right dose or we're not testing it and then deciding if we should take it. We just heard it on some podcast that X supplement is good for, XYZ, so you'll end up taking it. This was a classic case. So this patient, like even the next patient, they're quite informed. Like they're already watching podcasts. They've read a couple of health books. Already worked with some other kind of people in mainstream medicine as well as conventional like alternative medicine. So yeah, she was taking selenium and like it was in part of the NAC she was taking. But when we tested the selenium came at 150. There's a wealth of literature on selenium going high, causing insulin resistance and like dysregulated glycemic control. So we have to remove the exogenous selenium in such cases and normalize like plasma selenium. Again, plasma selenium is like a validated marker for selenium status, has a lot of studies published on it. So yeah, this has been associated with insulin resistance. So we took that out. Like I had to, get her to stop. So yeah, this is again like more signals. So androgen elevation also causes insulin resistance. Like this is part of the picture in PCOS, which she did have. Like she didn't have, say, like irregular periods and couple of other classic symptoms, but she did have hair loss and she does have high androgens and stuff. So yeah, I mean, like, can diagnose her with PCOS based on the Rotterdam criteria. There's a couple of other conditions that need to be met, and they were met. So yeah, looking at higher testosterone, higher DHEAS levels, even if these are elevated and people don't have symptoms, they do worsen pregnancy outcomes. Like, we know that higher DHEAS, like, there's studies looking at higher levels and worse outcomes, and also a high AMH, which shows us polycystic ovaries. Like the Monash University guidelines of 2023, they basically state and give a lot of evidence for why AMH can now be used as a surrogate for doing like transvaginal ultrasound. So you don't have to run that and then count the number of ovaries. You can just do an AMH and then get a like evidence-based surrogate from that, which is why I say she fulfilled the Rotterdam criteria, and this is a PCOS case with at least hair loss as a symptom. And then we're looking at stress axis signals. So you have high AM cortisol. Again, cortisol worsens glycemic control, and testosterone DHEAS both worsen insulin sensitivity as well. So yeah, these signals can contribute to insulin sensitivity, variability, sleep issues, hair concerns, and overall inflammatory load. This is the protocol that she was given. So again, I have very like fine affinity and attention for detail when I'm kind of working with cases, because I want to make sure I'm, getting everything like as correct as possible. So in terms of the foundation diet and lifestyle, moving her to a Mediterranean diet, stopping the high saturated fat intake, like it's not that if you just have a little bit of saturated fat, you're gonna die of heart disease tomorrow. But certainly, like, there's a wealth of evidence on like extremely high saturated fat intake, increasing like ApoB, LDL levels, and then worsening glycemic control also. Like, they've done studies comparing saturated fat versus MUFAs and PUFAs. And per calorie, like, saturated fat does lead to higher insulin resistance. There's a meta-analysis of say 120 randomized control trials, which came to that conclusion. So yeah, you can't dismiss that kind of evidence easily because it's very, very high bar. So
Five
you
minutes
got,
to go.
sorry?
5 minutes. 5 minutes to go.
Oh, damn. Okay, cool. Calorie deficit and then high fiber. Okay, so that these all of these things have been shown to improve type 1, say, diabetes in trials, and then basically getting her to stop a bunch of supplements, getting her to stop the selenium, continuing with certain things, but optimizing the dosage, and then replacing quite a few supplements, like again, optimizing the dosage and things. Y'all can look into the mechanism and stuff later, but this is basically like what all I use. So we use resveratrol, minoxidil, black seed oil. Again, like, these are all combinations of different evidence-based kind of supplements at the right doses, supporting like having clinical trials for different symptoms and the blood marker issues that she had. So we used a bunch of these. Again, she's already on some of these, but the dosing and stuff wasn't right. So yeah, that's basically like what I got to change. And then the insulin requirements, like, this is the fascinating part. Like, we saw earlier, she was taking 3 to 6 units per meal, then long acting like 10 units nightly. After that, we're looking at just one unit with each meal, and that's like a crazy drop. Like, you're looking at 3 to 6 to like 1 unit every meal, and then long acting, you're looking at 7 units. So yeah, this is again like impressive drop. I have a voice note of the patient, like, kind of remarking on these improvements. You all can see the QR I've uploaded later. It has lot more of the kind of material that goes with the presentation because we don't have enough time. So you all can check it out there.
Like I told you now, I'm getting damn sensitive to the insulin. That's good. If I can actually be damn helpful if I can take half, because sometimes when I'm training, I need half a unit to stay between, let's say, 90 and 120. And I don't have that half unit, so I have to wait till I go to 155 to take the full unit to bring it down. If not, I crash. Oh, damn. Okay. Okay. So, and like I'm getting sensitive to the insulin, which is great because that's what you want. Even long lasting, I'm taking 7 units during one phase of my cycle and 8 units during another phase. Depends on how resistant I am. And if not, it's literally 3 units a day. One when I take the fibers in the morning, 1 unit at lunch, 1 unit at dinner. That's it. That is the high down from how much you were taking earlier. I would say about, my long lasting used to be 12. Okay. For the longest time. And I used to do about 3, 4 at each meal. So it's awesome. Yeah. It's a good problem to have. So you need to figure out how to, to get half a unit. Yeah, that's why I'm not complaining. Like, not at all. It's the first time in 6 years. The other day, I was able to eat an after-eight chocolate because I needed 7 grams more of carbs. I couldn't eat anything. I was like, fuck, this is 7 grams. I'm just going to eat it. And I was like, you know what? It's very good that I'm able to give myself this flexibility without spiking 130, you know?
These were the number improvements. So we got the HbA1c to go from 11.8 to 6.7. Big drops. Again, like ApoB drastically dropped. Fasting glucose like dropped. RF is not actually supposed to be used as a marker to see remission in RA, but reduced, homocysteine optimized. Again, like androgens also improved drastically. And then the risk matched the reality signal. At 11.8, I told her she would be expecting complications like retinopathy. And then later on, she was diagnosed with retinopathy like 2, 3 months after. The insulin requirements changed, and then the symptoms all improved. I'm quickly going to run through case two, and then we'll just wrap things up. Maybe just like we'll need 3, 4 minutes more than required time. We can, keep the Q&A for later. Like I can address the Q&A in the chat on text later in the chat. So yeah, this is case two, alopecia areata. Again, like month 0, month 5. Other issues, headaches on and off, irregular periods. Goals to regrow hair, fix any remaining thyroid issues, though she didn't have any when we did her blood work. Improve allergies, and then manage stress, anxiety, and learn long-term control. So again, these are all the symptoms that she came in with. This is the after protocol changes. Bald patches fixed, acne 90% better, headaches reduced a lot, periods on time, and allergies a lot better. What she's already taking, again, you can see similar patterns. Taking selenium, baseline selenium status high, got her to cut that. Vitamin D levels really high can lead to calcification and other long-term issues if you like push vitamin D so high. Although, of course, like high dose vitamin D does have like some beneficial effects on certain things, but then it does come with safety trade-offs in other areas. And then, yeah, she's already taking the supplements on the left, like when she came in with me. So this is how I went about like starting and stopping. Again, like she also has high atherogenic risk at baseline, high ApoB, LPA, low, like suboptimal omega-3 index, which is playing a role in her migraines. Very, say, like, again, like the previous speaker was saying, fasting insulin is not just a problem if it's above 25. We have data showing that even once it starts to cross 6, we start to see, issues kind of rise progressively as you get higher. So yeah, if you just ran fasting glucose and HbA1c, you would have missed her issue, and she does have PCOS. So this is important to capture the fasting insulin. Again, PCOS case, so androgen excess pattern. So in menopause and those kind of contexts, like yeah, you see deficiency of different hormones, but then with women, especially like in early years, youth and kind of bit after that, we see like PCOS is the primary issue that most women struggle with. So you typically see like insulin resistance, inflammation, high androgens, things like that. Um, Again, ferritin is very relevant to hair loss. So ferritin of 44. The other stuff I discussed, and then other biomarkers also like lower protein linked to hair loss. She did have H. pylori, which is one of I would say the main triggers for her alopecia areata. There's good research on H. pylori being a trigger for alopecia through different mechanisms, like other speakers have spoken about, and Dr. Tom yesterday, like molecular mimicry, bystander activation, and a lot of those kind of things. So yeah, we did focus on eradicating H. pylori for her. Again, did amino acids testing, so lower tryptophan levels. These are the pillars of the kind of strategy I followed. So fat loss plan, hair regrowth support, androgen cycle regulation, allergy migraine support, and H. pylori suspicion. So plan for that. Okay, quickly wrap up. So interventions, we're looking at say different like diet and hair. Again, you can like go and check out the details later in the slide. Just scan the QR like after the presentation, and all of this will be there. So we're looking at different nutrients, insulin resistance support, energy support, hair support. And then for migraines allergy as well as H. pylori, then H. pylori like separate protocol with different evidence-based nutraceuticals and dietary strategies. And then we're also looking at different supplements to support migraines and kind of insomnia and things like that. Clinical outcomes, again, alopecia areata, bald patches filled, acne 90% better, headaches, migraines reduced a lot, periods on time, allergies a lot better. These are the kind of number outcomes. Ferritin, again, for hair loss, we're trying to target ferritin above 70. So we got there. Other biomarker improvements, selenium normalized, insulin almost there, optimal. Fasting glucose improved, ApoB dropped, androgens improved. Like you can see, the androgens have had a big drop. Like DHEA has gone from 470 to 197. Testosterone also like optimized, androstenedione dropped, and then the free androgens also reduced. So yeah, just wrapping up. These are two case studies. They're not cherry picked. I have a whole repository of case studies like this. So if you want to see before after markers, symptom improvements, patient experience feedback, case results across multiple symptoms and diseases, just scan this QR and you can check it out. If you want to get all of today's slides and much more, so like scientific references for every single thing I've discussed today. I don't like to leave anything kind of addressed without backing it up with relevant citations. Pretty much for every sentence I'm saying. So y'all can go and check it out also in the QR, and then all patient testimonials, and then you can join my WhatsApp community and everything. I'll just check out the QR. I also teach this professionally, so I have a course designed for this, like how to crack 190 biomarkers, 30 plus symptoms, how to interpret, rank, and apply scientific studies. Basically, teaching you all how to fish instead of just handing you all say protocols, what to test, how to interpret, how to deeply build personalized evidence-based protocols just like this and get crazy results. Practical templates you can use immediately. So I cover like say 3,500 plus studies in my course. All of that summarized in Excel sheets with dosing, links, contraindications, optimal ranges. And then you also get to apply it practically. So you have to solve a case study at the end of the course, and then you get in-depth feedback from me. So it leaves you extremely practical. At the end of it, these are all again like if you're interested to work with me one-on-one, these are all the kind of things I offer that you can check out at your own pace later on. Thank you so much for your attention. Lovely presenting today. If I have any
Thank
time.
you so much, Johan. I can see, yes, we have exceeded the time, but I can understand why we have exceeded the time because there's so much complexity in your case. So definitely, you have really pinpointed a very important aspect that taking supplements blindingly can really, really create havoc as well. Something that we definitely should be very mindful about what we are taking. It should be therapeutic. There should be a meaning as to why we're using something. What are we trying to correct? Definitely looking at the root causes in the right manner. And congratulations to your journey as well. Very nice story said in the beginning. Definitely very inspirational. I want you to stay back and also check into a couple of questions which have been posted for you. Kindly answer them. I will not be taking them because in the interest of time. Thank
Sure.
you. Thank you, Johan.